So a warm welcome to this Eckert & Ziegel and Pentixafor Satellite Symposium on Theranostic Innovations. So now I would like to start my introduction to the Theranostic roadmap, and it's termed the long or the short way from diagnostics to therapeutics. And there's a reason why I mentioned the long or the short way. I mean, we have several theranostics concepts that are successfully used in the clinic, and no one really reflects anymore on how we got there. How did we get from diagnostics to therapeutics, or the other way around, and what did it take? So since I'm a chemist and radiopharmacist at heart, I would like to go back to the chemistry behind which are the theranostic concepts that are currently in the clinic, and what are the differences between those concepts? Of course, I mean, I don't have to mention it's almost, let's say, normal. The first theranostic concept that has ever been implemented, it's the complementary iodine radioisotopes that are successfully used. But then, of course, we also have the radiohybrid compounds for PSMA, which are specific because you use the same chemically identical compound for diagnostics and therapy. And then we do have another concept where you use the same precursor for diagnostics and therapeutics. So you have chemically identical labeling precursors, but by labeling with two different radioisotopes, a diagnostic and a therapeutic one, you have slight but relevant structural differences between the diagnostic and the therapeutic agents, and they do influence somewhat the biodistribution and the characteristics of those traces. And of course, you all know dotatate, PSMA, INT, the FAP-targeted peptides that are currently emerging, and then also the FAPI46. And then sometimes you have to go a very long way to go from diagnostics to therapeutics. One example where the way was long, but not that long, was the way from Pentixafor to Pentixater, the two CXCR4 targeted agents that are going to be discussed today. And then, of course, we can go the very long way from a dedicated diagnostic agent, such as PSMA-11, and then go to a dedicated and adjusted therapeutic agent. And I would like to go first, on what are the requirements? Why are the ways so different in length? Usually, I mean, you've all seen this. Everybody knows what we would wish for in a perfect diagnostic tracer and what we would wish for in a perfect therapeutic agent. And there are, of course, differences, because for diagnosis, you want early high-contrast imaging, you want rapid clearance of your tracer, high accumulation at early time points. And then, if you're lucky, you might also wish for being able to extrapolate your therapeutic dosimetry from the diagnostic agent. But for the therapeutic agent, of course, the requirements are logically different. You want to deliver high radiation doses to the tumor, you want to spare the healthy tissue, and basically you want a maximum area under the curve in your target tissue. And of course, if you use the same molecule for exactly those two very different applications, you run into problems. You have to either find a good compromise or really go for the very long way from a dedicated diagnostic to a therapeutic agent. And I think the best example for going the very long way is the way from PSMA-11 and PSMA-16. In PSMA-11, it has ideal characteristics for imaging. You have a high affinity, but there's a specific chelator used for chelating gallium, which could not be used for a therapeutic agent. So it took a series of optimizations of the linker structure of the chelator to end up with PSMA-617. And I mean, you all know the clinical data. I just showed again the first preclinical data and the comparison of those two compounds, and there are really two dedicated compounds with exactly the features you would wish for in your diagnostic and therapeutic companion. Then I come to the short way, which, as you all know, is also a good compromise. It's gallium and lutetium dotatate. You have the same ligand, but you use different radioisotopes. And as I mentioned before, just introducing this different radionuclide changes a lot in the compound. As you can see here, even going from gallium to yttrium, which is similar to the lutetium complex, you lose 8-fold in affinity. But this loss in affinity is not that bad, because actually you because you have less affinity, you have less uptake in the endogenously somatostatin receptor expressing organs such as the spleen, as the pancreas, the adrenals, but you have a slight increase in kidney uptake, which you would not wish for, but it is still a good compromise. And this, of course, is also demonstrated. It has a huge clinical success. It is good enough. And it's also shown that there are more than 50 abstracts in this meeting on this theranostic concept. But of course, even if you go the short way, that doesn't mean you can't move on. And this longer way is currently taken onward to the improved targeting, therapeutic targeting using somatostatin receptor antagonists. Now let's come to the long way towards CXCR4 targeted diagnostics in the first place. It's just a little history of Pentixafor. It took many years to downsize the, let's say, native ligand for CXCR4, which is SDF1 alpha or CXCL12, to find a small cyclic pentapeptide with exactly the same binding affinity. And then, in my time in Munich, it took more than 250 different compounds to come up with a version of FC131 that could be radiolabeled with gallium and also had suitable pharmacokinetics, because the iodinated version had high affinity but unacceptable pharmacokinetics. So that was the long way to the imaging agent. And then it was, fortunately, very successful. There were many, many examples in hematological cancers where there was excellent uptake in the tumors. And this is going to be presented in much more detail, the clinical data by Professor Françoise Kréber-Baudry and also Andreas Buck. And of course, seeing that high tumor uptake, it was the next logical step to say, okay, for dotatate it works, we're just going to use lutetium in the same compound and maybe have a theranostic concept. But unfortunately, in this case, the theranostic roadmap, you sometimes have to take smaller deviations because it just doesn't work. Because when we try to radiolabel Pentixafor with other radionuclides than gallium, it was not very well tolerated. So we lost affinity once we labeled with lutetium or yttrium. And there were only very rare cases where we got similar affinity to gallium Pentixafor. So the question was, what can we do to actually circumvent this problem? And it took another series of optimizations, and then we came up with lutetium Pentixator. It's a small change, but the substitution of the tyrosine in this position for iodotyrosin saved us. As you can see, the effect on the affinity is really good. We even have higher affinity for lutetium Pentixator and yttrium Pentixator compared to the gallium Pentixafor compound. The selectivity of the compound is still very high for human CXCR4. We have a little gain in mouse receptor affinity. And then also the effect on the biodistribution was kind of unexpected. If you look at the preclinical biodistribution here, you find surprisingly high uptake for the tracer in the liver, in the spleen, and in the lung, which was not anticipated, and it's not justified by changes in lipophilicity. But this is basically because we all of a sudden target mouse receptor positive tissues. And the therapeutic application of Pentixator is also going to be discussed by the first two speakers in the patients. Then in the second part of this symposium, we're going to see a slightly, let's say, more extended approach to the theranostic roadmap. There's an alpha-V beta-6 targeted imaging agent that shows very promising clinical results, especially in PDAC. And besides using this imaging agent for selection of patients with alpha-V beta-6 positive tumors that might then be treated by a therapeutic companion to trivahexin, there's also the possibility to kind of implement theranostics in an extended sense by using it for alpha-V beta-6 radio-guided surgery or also fluorescence-guided surgery to develop drug delivery agents on the basis of those targeting units, and then also use it for clinical decision-making. Simply, do I operate a patient? Don't I? And those data are going to be presented by my ancient old colleagues from Munich, Johannes Notny and Jakob Simicek, who are now trimmed company owners. And okay, then we have another presentation where basically theranostics are turned around in a way. There is already a therapy, targeted radioligand therapy, using a single domain antibody-based platform. And now the question is, how do we assess therapy success? And of course, it's the other way around. You already have a therapeutic agent. You need to turn around and then develop the companion diagnostic that allows you to actually select patients and to do therapy control. And this is going to be shown by Dr. Matthias Heivetter from Precirix, who have this pipeline of HER2 and FAP and folate receptor targeted single domain antibodies, which are already entering clinical phases in the therapeutic setting, but are now going to be complemented by the adapted diagnostic agents. And basically, to sum this up, what we're going to see today in the symposium is basically gallium in the theranostic roadmap is and probably will always be, because gallium labeling is one of the easier radio labeling methods at the center of theranostic concepts. And sometimes you only have to walk a short way to get to the corresponding lutetium or actinium labeled compound for your therapy. Sometimes you have to take longer ways, more modifications to your molecule to get to different therapeutics. Then sometimes you have to take many bends and many different deviations to come to your appropriate theranostic agent. And in some ways, you also come from a different radioisotope, as for the Precirix compounds, and come back to gallium to implement your whole theranostic concept. And this is something we're going to hear in detail today during the symposium, and I would now like to ask Professor Buck, as our first speaker, to come to the podium and take over.